Thank you everyone for joining us, and welcome to the latest Duke Media briefing on the COVID-19 pandemic and its effects on society. I'm Allison Jones with Duke University Communications. So the FDA recently approved vaccine booster shots for people with compromised immune systems, and vaccine booster shots could be more widely available soon. With us today to discuss vaccine booster shots is Cameron Wolfe, MD. Dr. Wolfe is an infectious disease specialist at Duke Health and an associate professor at Duke University School of Medicine. His areas of study include infectious diseases and biological and emergency preparedness for hospital systems. Dr. Wolfe, thank you so much for joining us.
Hey, thanks so much for hosting this. It's a good topic. Appreciate it.
So Dr. Wolfe, the FDA recently authorized a third COVID vaccine shot for people with compromised immune systems. Can you explain who that affects and why these shots are needed?
Yeah, it's a great place to tee off because I think it'll build on many other things that we talk about. Specifically, what they did is that they've tried to really carve out a small niche. We think about maybe 3% of the community in whom over time we've learned that the magnitude of response to the vaccines, as we know, has not been as effective as we hoped. And so this shouldn't serve as a surprise for people. There's immunocompromised individuals who we would look after every day, particularly in a hospital setting, who are known for plenty of other vaccines to not mount a sufficient vaccine response as their healthy colleagues. But really what this data was built around, it was built around an increasing number of trials, particularly in the solid organ transplant world, but also in folks who've had hematologic malignancies especially, and looked at their antibody levels, looked in some instances at their cellular response and their memory of having been vaccinated. And not surprisingly, that defense, if you will, was seen to be on average less in these people. It's led to a number of questions of, well, what do we do about that? Is that something we should expect? Does that translate into reduced protection, or is it just a measure on a lab test? We can get into the weeds of that if you like, but really who we're referring to is very specifically those people with more significant end of the spectrum of immune suppression. So specifically, kidney transplants, lungs, hearts, liver transplants. Folks who are on active chemotherapy, particularly for folks who have solid tumors or liquid hematologic malignancies like leukemia. Individuals who, for example, might have HIV, where their control of their HIV is really poor and that's weakened their immune system. We know for many decades of HIV medicine that those folks do respond less efficiently to vaccines. This is true here as well. Excuse me. And then ultimately, the group that's perhaps the hardest to characterize is an array of people who live in our population who take different immunosuppression meds for other things. So for example, there are a number of people who would take immunomodulatory and immunosuppression medicines for rheumatoid arthritis or other arthritides. Lupus, for example, is a condition that is often requiring of heavier set immunosuppression. People with multiple sclerosis, for example, would fall into that category. So all of those individuals we now think and have a good understanding, I think, that the magnitude of their defensive response that they make to a vaccine is likely less. And so the idea of a booster then becomes, can I prop that up? Can I, with a third dose, can I bring you up to a level that may be comparable to the 2 doses, for example, that we usually give to someone else? And there's less data to show how effective that third dose vaccine is, but it's important because it's all singularly in the direction of improving vaccine responses in these individuals and without generating more of a safety signal. And we can get into the weeds of what that means too, if you like. But it's clear that we're trying to carve out a group of individuals who we know to be at higher risk of severe COVID. That's number one. We know that their on average response is poorer to vaccines, so we're trying to give them a little bit more. That is exactly the same as what we do each year for someone who gets a flu vaccine, and I sit in front of them, for example, and recommend a higher dose vaccine to someone who's immunosuppressed. And we are deliberately putting those individuals ahead of the rest of the general population, even folks who might be at otherwise higher risk of COVID, because they've not had the chance to respond as efficiently. And I think that's probably the most important subtle difference. This is, I can take 2 individuals, one, for example, a kidney transplant patient, and one, say, an older diabetic who may be overweight, and they're both at increased risk of severe COVID outcomes. but the transplanted person is at uniquely higher risk of not having built a defense from the vaccine, and therefore we're trying to prop them up even more.
Terrific. That's so helpful, and there is a lot to dig into there. We'll take questions now, and thank you to everyone who submitted questions in advance. You can also pose questions via the Q&A window at any time. If you'd like to ask your question in person, raise your hand in Zoom and we'll unmute you when your turn comes around. And if you're calling in by phone, you can raise your hand by pressing *9. Thanks also to everyone who's watching on YouTube. So, Dr. Wolfe, you've been describing the booster shots that are available now for this small subset of people. However, there has been discussion of making boosters available more widely. And that could happen perhaps as soon as September 20th, pending approval from regulators. What do you have to say about that? Is that a good thing or not? And how is that affecting healthcare providers, if it is?
Yeah, it's a good question. So obviously we've signaled through the White House and through HHS that is an intention. I think I'd start by what we talked about before. I think it's more important, first of all, to signal very clearly that we know there are some people within the community who wouldn't have responded to vaccines. Well, let's target those first. That's our immunosuppressed group. There's very strong consensus that that's the right thing to do and that group should be supported more. I think what's a little more challenging is to say, what does this mean for the general population? And so vaccines really, if you think about it, are driven to do two things. They're driven to both protect, ideally, from infection occurring in the first place. But in particular, what we've seen with COVID vaccines is that there's a huge benefit from those who reduce the severity of their infection, even if they're one to sadly get sick. And so, this audience would be very familiar with the profound reduction in hospitalization and mortality in individuals who are vaccinated. So what's really important with that decision is we're trying to carve out an understanding of, over time, expected vaccine waning from an immune system point of view. And we're getting good data from our colleagues in Israel and the UK who've not only vaccinated aggressively early on, but have also gone through a Delta variant wave before us. So they're providing us with a good lead example of what to expect. But importantly, we're trying to understand what is simply a waning initial defense on a blood test. How well does that translate into potentially a waning defense in terms of getting infection? And even if that occurs, does that translate into a waning protection against severe illness? And I think what we're starting to see out of particularly early Israeli data and again UK data is that there is a diminished protection that we're seeing at the moment in individuals who were vaccinated many months ago. It's a little more subtle to tease out, is that solely because it's a Delta variant and it's a virus phenomena that's allowing more people who are vaccinated to fall sick? Or is that something to do with waning antibody titers, or probably a blend of both, I think is the consensus at the moment. But it does certainly seem to be the point that somewhere between 6 to 8 months appears to be a point where that has become much more common. Now, it's difficult because that's also the same time when Delta variant has arrived. What has not had a big change is we haven't yet, fortunately, seen a substantial move in the proportion of vaccinated people who get sick enough to be in the hospital. There is a very small number of vaccinated individuals who are sick enough to land in the hospital. So when we talk about boosting for individuals in the general community, I want to be very clear, to me, that is far less important than still reaching those individuals who are not yet vaccinated at all. We need to continue to talk to those individuals about safety data and how robust it is, and about the profound difference in their risk of hospitalization and death by the simple act of being vaccinated. The people who were vaccinated the earliest in our community in the United States were healthcare workers, because we're in front of COVID patients all the time and continually potentially exposed, and nursing home residents, so the most frail and older populations in our community who were hit hard this time last year. And so they will also be on the outer edge of time when we look at duration of protection, and if there's a waning, they will probably feel that first. And so I'm going to be supportive, I think, when the regulatory agencies come to pass, and I think they will, that this moves forward, because I do think those individuals in particular, if there's going to be a larger load to bear for people getting infected and having breakthroughs, it's going to be front and center with healthcare workers and older adults first. And so, boosting those individuals early, I think, will be important. I think we need to see much more data to understand what the benefits of boosting is for the overarching general population who are lower risk. So if you're a 35-year-old who has gone through and had your 2 doses of Pfizer vaccine, for example, really has no risk of severe COVID and is not frontline healthcare working situation, that's different. I think we need to still see a little bit more data to fully understand why that person would need to be boosted and if that's absolutely crucial, even if it's related.
That's great, and you've gotten to some key questions in your answer there. So, are these booster shots? Here's a question from a reporter that came in advance. Are these booster shots a 3rd dose of the same vaccine, or has the vaccine been changed to provide wider coverage with new variants, including Delta?
Yeah, it's a good question. So what we're talking about so far is the same dose as what you had before. And so there's no difference if I turn up as an individual today with an immune suppressing condition and ask for my 3rd dose. The dose is exactly the same as what I would get if I'm turning up for my first. There's more detail behind that question, though, which is that, are we looking for varied boosting doses in a way that responds to the variants that are occurring around the globe? And the answer to that is yes. And so none of those sort of booster variants, if you will, or variant boosters, have reached the point of public dissemination yet into the general medical community. But Moderna, for example, has already started to release information about one of their variant boosters, which looks really looks favorable so far in its level of protection it generates. What's going to be an important weighed up question that I think groups like the FDA and the ACIP have to really think about, though, is to say, I have opportunities for people to receive a 3rd dose of the sort of old vaccine right now. And I am in the midst of a wave of Delta infections that may make that really crucial at the moment. And so a decision they have to weigh up is it important to give it right now? Or is it better to wait, in fact, for a sort of variant booster that may help us more against current or future variants, but may take longer to get? That answer is a sort of a modeling question in some ways. And I think for most of us who work on the front line of healthcare or for our transplanted or immunosuppressed patients, the risk is now. And so pragmatically, in fact, the right answer, I think, is actually to move forward with the dose that's available. That's the other part of why this conversation can even happen, is that availability is now wide open. We've heard of some challenges having access to J&J, but for the 2 mRNA vaccines, they are widely available. And so all of the sort of tiering and difficulties in terms of structuring access that occurred in December and January as we were ramping up our production cycles, they're fortunately just not an issue. So we can have these colorful conversations.
So a reporter question that came in: why is it important to wait the right interval of time to get a 3rd shot? The right interval being the one that the federal government is recommending.
Well, we'll see what the final recommendation is. I mean, I think the federal government clearly play a huge part here, but traditionally these have always been decisions that we've looked to colleagues at the FDA and the CDC and the Advisory Council on Immunization Practice, ACIP, to guide us on. I think the timing is important because in actual fact, there's a long history in vaccinology of sometimes waiting a little bit extra time is in fact appropriate to gain the strongest response. That's been seen and discussed a lot in Europe, where their use of the AstraZeneca vaccine, they actually believe they're getting somewhat a better response by delaying the gap between dose 1 and dose 2. The second issue is that I want to be giving a vaccine that's given for the right beneficial reasons, and the endpoint has to be prevention of infection, prevention of hospitalization. And so you don't need to do that earlier and put all the logistics and financial and medical resources into doing that too soon if the added benefit of that booster shot is diminished. So I don't think, for example, there's a great reason in an otherwise healthy individual who just was vaccinated with Pfizer or Moderna 2 months ago to go back and offer them a 3rd shot, absent some other medical condition, because they will have great protection. The question here is can we pinpoint more precisely the waning sort of durability of these vaccines over a 6+ month period, and find that sweet spot where boosting that protection in fact counteracts active viral prevalence that exists in the community. Part of the question that's important here is we've got a ton of Delta variant occurring at the moment and lots of infection. So now is the right time to be discussing this. But both of those factors sort of play into why the timing is important. How can I get the best juice out of that one dose? And how can I give it to you at a time when it's actually going to have the best benefit?
We're getting several questions about combinations of vaccines. If, for instance, one reporter asks, if someone got a J&J vaccine, would you recommend they get a Pfizer booster? Is it important that the third shot be the same as the vaccine that was previously administered?
Yeah, we sort of faced this same question at the beginning, didn't we, when people asked, like, does my second need to be the same as my first? And to some extent, the answer is that we know what the safety data is with following the third being the same as the second and the first. I know there's been trials looking at boosting individuals who've had a Pfizer vaccine with a third. I'm in one of those trials. We know in our transplanted patients, there's studies of Moderna and Pfizer vaccines boosted with the same type. It's not that we know that there's damaging or safety data aplenty in people who've had mixed courses. It's just that we don't know what the data is. And I think if we, many of us have always said all the way through this pandemic, if we're going to respond in a way that's appropriate and trustworthy, and we've got to be data driven in the way that we do that. And so all of the evidence currently is mounted for people who've taken the same dose. I'll get to J&J in a minute because it's more complicated in its real dearth of information in general. But so that sort of leads you to say, yes, I think you should take the same dose that you had for the original part of your course. What's interesting in the UK, at least in some parts of Europe, where they had that delay when they were using an AstraZeneca vaccine. So it's the same structure and same vaccine design as what we see here with Johnson & Johnson. They had some small studies looking to say, should we attempt to give the second dose of Pfizer and split their vaccine usage, or should we continue with AZ? And in fact, saw better immune responses when they were given a Pfizer vaccine. And so a lot of people have used that sort of surrogate information to say, maybe we should be mixing around, maybe you should be using something different. But at the end of the day, we don't know if that's just something that's unique about mRNA vaccines perhaps being more robust, or is it something that we should be trying to intentionally mix and match? Those studies remain to be done, although they're going to be very important. We have different pneumonia vaccines, for example, and we now understand that there's complementary ways that they can work together. I would expect in the next year or so, we'll start getting data to talk about the way that these vaccines can complement each other if crossed from one to another. But at the moment, that data doesn't exist, and we should follow what we know to be safe.
Makes a lot of sense. Should some populations be especially careful about booster shots? Is it particularly important? Would you signal that some populations should in particular consult with their physicians before considering a third shot?
Not from a safety point of view. I mean, I think the safety of boosting is the same as the safety in the first and second dose. This has actually been one of the remarkable successes about the story of COVID vaccines, is that they have been really safe on large numbers. I mean, I think you might want to carve out that a little bit for certain groups. So, for example, in the same way that I'm cautious about recommending a J&J vaccine to someone who's had complicated clot syndromes, I would probably equally be cautious about recommending a boosting strategy for someone who had vaccine-induced myocarditis the first time around. Now, that's a rare side effect, but we know it occurs, probably 2 per 100,000, I think was the most recent statistic, I'd say. But, if that was something that you had, I would certainly encourage that person to think about boosting strategies, but to do so with a real careful discussion with their clinician. Outside of that, there really isn't. Perhaps if you had one of those true anaphylactic reactions to one of the first vaccines, which we now recognize are incredibly uncommon, I wouldn't re-challenge that sort of person. But for the most part, they're very well tolerated. The one group where it's not a safety issue, but it's a question about how can I get the most benefit out of a booster, is people who say take periodic chemotherapy or episodic immunosuppression. And I think that is really a good group who should be sitting down with their oncologists or their immunologists or infection specialists to say, I'm on these variable immunosuppressions. When should I time my vaccine to get the most defense out of it in relation to the chemotherapy, for example, that I get? And that needs just to be an individualized discussion with your physician.
People getting the third shots, the booster shots, how strict is the criteria? Well, you described the criteria, but who's enforcing that criteria?
Well, it's self-attestation at the moment. So you can judge enforcement through my grin, I suspect, on that one. Look, at the end of the day, I've always challenged my own patients to say, I'll talk to you about whether this is going to be beneficial for you or not. I'll individualize the risk in front of you, and we'll look to see whether you fall into this early category for immunosuppressed boosters or whether you can safely afford to wait. And usually if I get to the point of saying, look, I think you can safely afford to wait, it's because I think your current defense is good and you'd gain more long-term benefit from, in fact, intentionally waiting. But at the end of the day, there are some people who will go up and self-attest that they're immunosuppressed or in a bracket in whom they should have a third dose. And it's, in an era where we have plentiful supply, and I'm not sort of using a scarce resource like we did early in December and January, that's much more wide open.
We have another reporter question. This is from Hillary Brooks. She's asking, following up on your example of a 35-year-old who was recently vaccinated, if people are young and healthy and they boost themselves too early, is that a waste of a shot? What benefits could that person derive from a booster at that point? And can you unpack that immunology just a bit?
Yeah, sure. It's on the most simple level, it's how much benefit do you give for the effort that you've gone through. And so, it's true to say that the proportion of people who have had side effects due to boosters is going to be very similar, if not a touch higher, than the people who've had side effects on their second dose. We know they're common in these mRNA vaccines in particular. Perhaps a third to 40% of people will get some side effects, and I expect that they will continue on their boosters. So people will take some effort and experience some issue in relation to taking these, safe as they are. So if you're someone where I think the proportional gain, if here's 100% protection, which we know we can never quite get anyone to, but you've already got fantastic level of protection from your recent boost and from your recent original course, and the booster only gives you a tiny bit of gain, that's just proportionally less useful, frankly, than the person who might have had waning immunity over 8 months or never got good immunity because they're a kidney transplant. That person, I've got a lot of desire to want to, frankly, get better. The immunologic question is a little more complicated, and I think still being worked out, which is there is a certain time at a minimum which we lay down our immune memory. And that memory, if boosted too soon, does not lay down in quite the same effective fashion. It's not detrimental, it's just not necessarily as effective as a later boost. So, for example, there's healthy debate amongst immunology circles as to whether the difference between a 3-week dose gap in Pfizer and a 4-week dose gap in the Moderna series, in fact, naturally afforded a little bit of advantage and durability to Moderna. That's pretty theoretical immunologic difference, to be fair, but it certainly adds weight, I think, to the argument that people shouldn't necessarily just rush up and boost straight away if they otherwise have no real need for medical boosting.
Another reporter question: what's the difference, if any, between the third dose being given to immunocompromised people right now and the possible booster that all Americans could be eligible for later this month if FDA approves that?
None. They're exactly the same. So the booster is the same. The dose is the same. The probable benefit is very different, I think, based around what we talked about earlier, that the gain, if you will, from someone who didn't really respond very effectively the first time is different. So, there's been a couple of good trials in kidney transplant patients, like I mentioned before, where that added gain in that third dose can be really profound in people who are immunosuppressed. So University of Toronto, for example, just had a really nice study a couple of weeks ago in the New England Journal of Medicine where they took a cohort of their lung, heart, kidney, and liver patients. And in fact, the difference after the third dose of their Moderna vaccine, when you looked at assays that measured not just antibodies, but capable antibodies, neutralizing antibodies, they sort of moved that group from a median of about 20% protected up to sort of 65. It was really quite a profound difference that third dose finally gave them. And in fact, a French cohort the French have been doing this for some time in their immunosuppressed group with the Pfizer vaccine, and they had the similar sort of results where about 40% perhaps of individuals have had meaningful antibody protection levels after their second dose, and yet after their third, that sort of bumped up almost to 70. It's still less than a otherwise healthy individual, but it makes a big difference for those people. I digressed a little bit there from the question, I'm sorry, but functionally the injection is the same as what's being talked about a month down the road, because I don't think the true variant boosters will be available by that stage.
So beyond this, the current issue regarding potential boosters, do you think we're potentially looking at the reality of an annual dose of the COVID vaccine, like the flu shot?
Yeah, I mean, a lot of people talk about that, and I think that remains to be seen. I'll be totally honest. So when you look at the other boosters, for example, the other types of vaccines that we boost with, there's a few, and in fact, a few of them end up with, once you're boosted once, you really get lifelong protection. So for example, hepatitis A, I'll dose you once, I'll dose you again in 6 months, and the memory of that response is phenomenal, and we presume lifelong. Shingrix is another good one, which is like mRNA vaccines, incredibly immunogenic. Dosed once, dosed 6 months later, presumed lifelong defense. The difference here, though, with these is not on the immunologic side, although we're still learning what the durability of long-term mRNA defense is. The difference here is that we're, unlike hepatitis A or shingles, we're dealing with a virus that mutates. And so I think that's the other factor here that we have to think about is I don't think anyone would argue that we haven't had perfect global control of COVID yet, nor do I see a horizon where that's likely. This will be an endemic virus. And so the way that it changes will affect the effectiveness of vaccines. And we have to continue to follow whether vaccines in that context continue to be necessary to keep what I think will be an otherwise common cold virus for the majority of us who are well vaccinated and well protected. If it stays like that, actually the need for further sort of annualized vaccinations may diminish quite substantially. If you get a variant, for example, that emerges, or overall waning immunity such that we start seeing those severe cases really creep back into the community again, that's a whole different issue. Similarly, we may stratify that based on individual risk. So for example, I already give more boost of an annualized flu vaccine to my folks over the age of 65 because I know their risk increases and their side effects are more significant to the virus and their immunity depletes quicker than, say, mine as a 45-year-old. So that remains to be learned. So open question.
So we have a question from a reporter who asks, does it make sense for individuals to get an antibody test, a serological test, to see whether they have enough antibodies? And if antibodies are lacking, would that indicate the person should get a booster?
Yeah, that is a really common question. And I get 1,000 questions from colleagues and patients who even sometimes have gone and got this and then say, hey, what do you think this means? And the truth is, I don't know what it means. The challenge there is threefold as I see it. Number one, we've never had perfect clinical data to understand at what threshold your antibodies are sufficient to protect you. So when someone comes to me and says, my level is X, I don't know what X means in relation to their immediate risk. So that's issue number one. And folded into that is they're only measuring one small part of your immune system's defense. Like when I mount an immune response to a vaccine and therefore an immune memory response to an illness, I'm not only mounting an antibody response, but I'm also mounting a cellular response with my white cells remembering having seen this before. An antibody test tells you nothing about your cellular defense. we think it's mainly antibody defense that controls this, but it's not exclusively. The second issue is that there are a variety of different antibody tests, and unfortunately, they're not cross-comparative in easy ways. Some are qualitative, they just say positive or negative. Others are quantitative. Some look only for the development of anti-spike antibodies, which you would see both in a vaccine, but also potentially from natural immunity, whereas others take other pieces of the virus that are not found in the vaccine. And if you've mounted a response against that, then they can tell you, yeah, you actually already had the infection as well. And so some of the early papers, for example, that came out showing different levels of protection with different vaccines had a wash of different antibody tests, making cross-comparison really difficult. Perhaps it's more useful in someone who comes back with a test that says, look, I have no antibodies. Okay, well, that tells me something. You really didn't make a response, at least on an antibody level. It doesn't tell me if you're more or less likely to make a response to the booster dose. I mean, I'll certainly recommend that person get one. But honestly, if they had something about their immune system that led them to have no response to the vaccine in the first place, I'd be recommending them a vaccine either way, because even if they had antibodies, I wouldn't know how protected they were. So where I'm going with this is we've generally circled around not recommending antibody tests outside of sort of research settings or settings where we want to see how much COVID has been in a community. I think that's where their role are. It's not for individualized tests, even though plenty of companies are making a bucket load of money from selling them. I don't know the results are in any way interpretable.
So we're running just a little bit over. We'll try to get to just one or two more questions, and then I know you'll need to head out. Is there anything we learned from the vaccine rollout in the spring that should be applied now to this question of booster shots?
Yeah, there's probably a lot of things. So number one, I think most healthcare workers, like all of my physician colleagues, are asking me frequently, like, when can we get this? When does it make sense? That is a uniform response amongst almost all of my physician colleagues. And so, we learned a lot operationally as a healthcare setting, for example, as to how to roll out vaccines in ways that didn't operationally hamstring our clinical practice. So I think those sorts of logistic questions we are far better prepared for. People better understand the side effects that they get from a vaccine, and I think they can be then ready to say, I don't want all of the staff in my intensive care, for example, to go and get a booster shot on the same day, because the next day a good chunk of those may have some temperatures or fevers or muscle aches, and I don't want to accidentally short my own staff. I think otherwise, the other big message that we really haven't talked about here is, how do we communicate this? How do we talk about this in a way that displays data as clearly as we can? And I think it's been good so far in the way the vaccine rollout has happened, in that FDA and the companies were very open to say, look, here's all the evidence that we're using to base these approvals. We haven't seen all the evidence yet that the federal government has quoted us to talk about boosting shots. And I think it will be absolutely crucial when that data is made available to the CDC, for example, and ACIP, that is also available to the community, such that we can have these conversations in a way that helps them make an informed choice. The worst thing for vaccine hesitancy is either incorrect information or a data vacuum, because then I think people make their own stories and often end up in incorrect positions to make a decision. I think the final thing is we need to be very careful about continuing to splay divides in our community, either along racial lines, along ethnic lines, political lines. The vaccine rollout has done a good job, I think, so far at trying to address those head on. We've learned some lessons. It'd be naive of me to say we can't do better. There are still disparities in terms of vaccine access in different states, vaccine availability and take-up in certain communities. And we don't need to go into the politics of it, but there's clearly a political issue here as well.
So you've touched on two last questions here, and then we'll wrap it up. You've touched on this question, but it's an important one. So circling back, and a reporter is asking this, is there scientific consensus on the need for booster shots for those who are not immunocompromised?
Yes. When, I think, is a little bit open for discussion. and how much benefit I get versus you get, I think is an area that we'll have great interest in figuring out. Like I said, there is not yet consensus about whether it should be with a standard dose or a modified variant booster, but we don't have the other option right now. So I think it seems pretty clear consensus that we're going to move in that direction. I think the when is what we're trying to figure out.
So finally, what would you say to someone who is considering getting a COVID vaccine booster shot? What questions should they ask? What factors should they weigh?
Yeah, look, I get this all the time in clinic. I mean, I think the first is on an individual level, they need to understand what their risks are. First of all, from COVID itself, are they high risk for any reason? Secondly, what's their individual risk when it comes to whether they were likely to respond to the vaccine the first time? So that's their immunosuppression we talked about at the beginning. Thirdly, I think it's their epidemiologic risk. So are they in a workspace or in a family setting where there are many more likely transmissions, and to factor that into their calculation? And then who around them is at risk from them getting sick? Are they a teacher? Are they a healthcare worker? Are they someone who's looking after grandma in the house? Do they have a husband who's got a heart transplant? I don't know. But like, so there's individual questions, and then there's their community questions. And I think we underplay the community questions significantly. I then end those conversations, to be honest, by talking about the magnitude of the effect of our current wave on our community. And it's not just been extraordinarily stretching and fatiguing for hospitals. It's affected our ability to do standard practice. We don't manage other regular non-COVID illnesses as effectively as a community as we used to 6 months ago or a year, 18 months ago. We just don't. We don't have the space. We don't have the staff. Equally, if you're completely oblivious to healthcare concerns, everyone, I think, is conscious of trying to get schools back open, trying to get businesses back up and running, trying to economically make us tick along in a way that's efficient. And the economic argument is usually where I settle on, because it's not a political one. At the end of the day, we can all benefit by getting this under better control. And that is a collective benefit from an individual decision. And outside some extraordinarily rare side effects, that almost always ends on, yes, this is the right move for you. And for the most part, when people have had a chance to sort of dissect those thoughts, they usually go ahead and do it. If they don't, there are some people who have really chosen not to be vaccinated. I think it's my healthcare obligation to tell them what the other options are, both in terms of COVID avoidance, getting other people who are high risk away from them where it's possible. And if they, heaven forbid, get sick, we talk about antibody strategies and different things to infuse to make them safe.
Thank you so much. We'll call it there. We're a little bit over time. Really appreciate your joining us today, Cameron Wolfe.
There's probably one question which I skipped early, but I do think it warrants an answer, which is J&J, if you don't mind.
Yes, yes.
I am struggling, like everyone probably in this audience, because there's no data visible and no commentary visible on the J&J vaccine and whether that should be counted in anyone's boosters. And the reality, sadly, is that there's not visible data to the community yet that speaks to how effective they will be, either going from a J&J boost to something else like Moderna or Pfizer, or data which we know is coming in a couple of weeks about using a J&J boost on top of the first J&J. The company has signaled that data is in fact incredibly reassuring. And if that's true, then I think that it's worth us collectively waiting for a few weeks to better understand what that really looks like. Because in fact, I'd hate to be recommending widely to people, I don't know, so go and get a Pfizer vaccine, when in fact, it may only be a few weeks down the road that we get much better clarity about how good a J&J booster is. So sit tight. I apologize for the dearth of data in that regard. It's frustrating, but I think there's good information coming and we need to read it.
Super. Well, that's a great clarification. We'll end there. Thank you to everyone for joining us. Thank you so much, Dr. Wolfe, for sharing your perspectives. If you'd like to attend future Duke briefings on the COVID-19 pandemic and other topics, please email dukenews@duke.edu. In the meantime, please stay well. Thank you very much.
Thank you.